The topic today is going to be ADHD and behavioral disorders. When I first got interested in ADHD and behavioral disorders, having had 5 children of my own, and knew their friends, the belief generally at that time was that it really had to do with life experiences and stresses and problems that it really emerged along with problems in life. And what we learned is that in fact most children that have ADHD were born with a tendency for that, and it has to do with their brain chemistry. The Walsh Research Institute is a public charity, a 501c3. Our expertise is basically in brain disorders and brain chemistry and neuroscience. As Dana mentioned, we have a physician training program that has now reached more than 600 doctors throughout. I think we now have 30 different countries where we have doctors doing these therapies, these protocols that I'll be describing. And we're also very active in research. We recently believe that we have found the underlying mechanisms of bipolar disorder and presented that recently at the American Psychiatric Association annual meeting. We also have a very active schizophrenia research project going on. So with ADHD, we have, I think, possibly the world's biggest chemistry database for ADHD. It encompasses 5,600 patients where we have great detail of their blood and urine chemistries. We have more than 500,000 blood and urine chemistries. And equally important really are the medical history factors, because the symptoms and traits of a child or an adult tell you quite a bit about their chemistry, their brain chemistry, and their chemical imbalances. So the first thing we found was, in looking at our database, is that people with ADHD are different from the rest of the population in many ways. And they're different in different ways for different people. For example, we now know that 68% of all children diagnosed with ADHD have abnormally high blood copper levels. And I'll be explaining why that's important, why that directly affects a couple of important neurotransmitters in a very massive way. They also have insufficient ceruloplasmin, that's 92% of them, and that's a protein that helps manage copper. And so if you have too little ceruloplasmin, that is a marker for oxidative stress. Zinc depletion in 96%. In other words, the population, only 4% had an ideal level of zinc. We use the word depletion instead of deficiency because that includes people who are low normal and would be better off if they had a higher level. Methylation disorders occur in more than half, 55%. Pyrrole disorder, 30%. And malabsorption, a relative inability or inefficiency in utilizing the nutrients in diet, that's 11%. So let's start as an example with copper imbalance. This is more than 2/3 of ADHD children and actually also adults. Copper levels are regulated in your body by metallothionein, which we call MT because it's easier to say. And that is a genetically expressed protein that has the job of keeping our copper level normal regardless of what's happening. I always tell people that if you could even be chewing on bars of copper, and if your metallothionein system is working, your blood levels will still be quite normal. But that system doesn't work for everyone. Their metallothionein genetically expressed has these things called SNPs or weaknesses that some people have and others don't, and that can impair the ability to keep copper levels where they belong. And so these SNP mutations can result in copper overload and zinc deficiency. The two tend to go together. So for us, the copper zinc ratio is important. One of the most important things for ADHD is that excess copper severely depletes dopamine levels. So Ritalin and Adderall, the very medications used effectively in many ADHD patients, what it primarily does is it increases dopamine activity. Well, here we find that 68% of all ADHD patients have a chemical imbalance that's correctable that can boost your dopamine activity. And we find that many patients who have been on Ritalin or Adderall, once we correct the copper level, they no longer need the medication. And basically, low dopamine function is considered the #1 associated factor for ADHD. So just to give you an example of this, this is the synthesis of norepinephrine. All of our norepinephrine, which is a neurotransmitter, comes from dopamine. And this is happening right in your brain cells. And this figure shows that reaction. You have dopamine on the left, and then with the assistance of an enzyme called dopamine beta hydroxylase, that's one of the most famous enzymes in biochemistry, together with copper, divalent copper, copper plus, vitamin C and oxygen, then that results in norepinephrine. Now the copper actually has to loosely bind to that enzyme for this reaction to go. So if a person has excessive copper levels, which happens in more than 2/3 of ADHD kids and adults, you have too little dopamine and far too much norepinephrine. Dopamine, as I mentioned before, is central to ADHD, and that's why the medications are aimed at elevating dopamine. But this is the reason why many of these children and adults have low dopamine. And norepinephrine, that is a neurotransmitter that has everything to do with hyperactivity. And so it's a double whammy. If you have elevated copper, your dopamine levels will be low. That'll cause inattention and distractibility and many of the problems associated with academic attainment in school, and then also the hyperactivity because of the norepinephrine. So we know why this happens now. We also know how to fix this. So the process we use is a medical process. We call it individualized nutrient therapy. And our goal is to normalize, to balance and normalize neurotransmission, especially the neurotransmitters that have everything to do with ADHD and proper use of your brain. So medical history and review of symptoms is really important. And the reason is that the chemical imbalances have a tendency to exhibit themselves with certain traits and symptoms. For example, I just mentioned high elevated copper. Well, they tend to have difficulty focusing, and they tend to be, in general, hyperactive. Methylation disorders are also similar. Every one of these imbalances you can pretty much predict the blood results once you do a really good medical history and review of symptoms. And of course, we need special blood and urine lab tests to find out exactly what are these chemical levels. Are they normal? Are they in where they ought to be, or are they abnormal, and are they affecting the brain? And based on the history and then together with the lab work, then the next step is to diagnose chemical imbalances, and then we develop and design a prescribed nutrient program aimed at normalizing brain chemistry and neurotransmission. So that's basically what we do. The major types of ADHD, these are listed in the diagnostic manual for psychiatry, and there are 3 major types: inattention, hyperactivity, and impulsivity. And then the third combination is people who have a combination of 1 and 2. In other words, they have inattention, hyperactivity, and impulsivity. In addition, there's a very high what they call comorbidity, where not only does many of these children have not only ADHD, but they also have a behavior issue. That behavior disorders are often part of it. And I'll talk about that in a few minutes. So let's first focus on number 1, the number one type of ADHD, which is typical inattention biochemistry. The defining factors are, number one, low dopamine activity, copper excess. They tend to have low activity of GABA. GABA is one of the two most common neurotransmitters, and GABA itself is a neurotransmitter, and tends to be low in these children and adults. And then, as I mentioned before, zinc deficiency or depletion. So the treatment approach for this group, we need to increase neurotransmission at dopamine and GABA receptors. And fortunately, we know how to do that with nutrients. Yes, there are drug medications that can do the same thing, but we feel that this approach is really the first thing to do, and that the drugs are more of a last resort. So what is our treatment doing? We're inhibiting expression of reuptake proteins. Now that may seem a little technical to some of you. The neurotransmission of dopamine is dominated not by the amount of dopamine in your brain, but by reuptake, by the ability of the dopamine, once it's shot into a synapse, to get back into that original brain cell, that original brain neuron. And it's controlled by reuptake. And we learned that about 30 years ago. And that was the time when, for depression, for example, the focus medically went toward reuptake inhibition, like Prozac, Paxil, those things, those drugs for depression, because they knew that reuptake was the real issue. Same thing is true for ADHD. And so our treatment approach is to inhibit the reuptake that would trap the dopamine in the synapse longer, so you get more effectiveness of that. And the specific nutrients we use are zinc, B6, methionine for those who, because nearly everyone with low dopamine activity is undermethylated, so we tend to dose them with methionine, or a nutrient called SAMe, S-A-M-E, which is you might think of as activated methionine, to enhance methylation, and again, to elevate dopamine activity. Now, to illustrate this, I've got a number of case histories. Now, this is for inattention. This case history is, I think, quite typical. A young man named George, age 10. Now, he had good behavior. He seemed to be motivated. He's trying to do his best, but he had very, very poor concentration. A number of people would call him a space cadet. And his diagnosis was ADHD, and it seemed to be a correct diagnosis to all of us. He was in special education and was taking Ritalin, and the Ritalin was helping him, although it tended to affect his appetite. And in fact, his growth chart showed that his growth rate had declined a bit. And also his serum copper was shockingly high. A normal level for copper in blood is between 80 and 100, and he was 163. And his plasma zinc was very low at 68. The ideal level for zinc is between 100 and 120. So George was born with a really nasty copper-zinc imbalance, the very chemistry that causes low dopamine activity and a tendency for an overactive brain. His histamine level was an 82, which is somewhat high, and that tends toward low serotonin activity and low dopamine activity. In the case of ADHD, it's the dopamine we're more concerned with. So anyway, this is what George had. His chemistry was terrible. We always rejoice when we see a patient who has terrible chemistry, because chemistry can be corrected. And very often you can eliminate these inborn tendencies and problems. So we treated him with zinc, B6, selenium, which is a really good antioxidant, methionine to elevate his dopamine activity, and antioxidants, vitamin C and E. So the outcome, we've learned through experience with more than 5,000 cases that when a patient is on a medication, such as Ritalin or Adderall or whatever, that we get our best results if we keep them on the drug medication. So we like to do both together, usually for at least 2 or 3 months. So we continued the Ritalin, which was helping to some degree during the initial deuterium therapy. For the first 3 weeks, not much happened. And the reason is it takes about 6 weeks to normalize elevated copper, to fix a copper zinc imbalance. So the family said nothing happened the first 3 weeks. But after 3 months, his academics were much improved. He no longer needed special education. And his psychiatrist weaned him off of Ritalin, not to get rid of the Ritalin, but to find out now that we had a new reality and he was better, the question is what would be the optimum dose of Ritalin? And so they very slowly lowered the Ritalin level, and we were told that he was at his best with 0 Ritalin. Now I want to mention that about 20% of the time in a case like this, we find that the patient loses something if you go all the way to 0 with the medication, with the amphetamine. And we say, so be it, because we are not against Ritalin. We just want the child to be at their best. But even in that case, the dosage is so low that whatever side effects might be there are usually gone. So that's what happened in that case. So let's talk about hyperactivity. Not all ADHD, even though ADHD, the H means hyperactivity, not all of them have hyperactivity, but those that do virtually always have excessive activity at norepinephrine and adrenaline receptors. These are neurotransmitters that have a lot to do with your energy, and it has a lot to do with hyperactivity of your brain neurons. Your brains are just, if you did a brain scan of someone who was hyperactive, it would light up like a Christmas tree because there's so much activity going on. And I guess you would call it too much of a good thing. And usually it has to do with either copper overload or an imbalance called overmethylation. Overmethylation occurs in about 8% of human beings, but it's higher than that in people with ADHD, especially those that have hyperactivity. And we have a nutrient therapy that can help normalize methylation. Okay, so the treatment approach for hyperactivity is we want to reduce neurotransmission of these 2 neurotransmitters, norepinephrine and adrenaline. And we do that simply by normalizing serum copper and plasma zinc. And to do that, we need zinc, B6. GABA actually is a neurotransmitter that tends to offset excessive norepinephrine. That's how GABA works, and it's a calming neurotransmitter, and it slows down the hyperactivity of the brain neurons. And if the patient also had overmethylation, we would give them folates and B12. So not all of them get the folates and B12. Only those that are also overmethylated. So a case history for this case was another 10-year-old, Peter, hyperactive. He had poor concentration, and he was failing in school. He had an ADHD diagnosis. He was taking Adderall, which improved to some degree, although he did have some weight loss from the medication. His copper zinc ratio, just like the last patient, was very, very high. It was 1.8. That ratio really should be between 0.8 and 1.0. The other chemistries were normal, which was good because we only had to worry about correcting this particular imbalance. So what happened to Peter? He also was taking Adderall. And again, in this case, I'm sorry, he was taking Adderall, which we continued. We continued the medication during the first 3 months. His hyperactivity got slightly worse during the first week. We understand that because what we have to do is to get the excess copper out of these people's bodies. And if we do it a little bit too quickly, the copper level in the bloodstream for the first few days or maybe a week is even higher than before. So the hyperactivity sometimes gets a little worse the first week, followed by improvement, gradual, steady improvement. After 3 months, his concentration was improved. Academics were a lot better, and his Adderall was no longer necessary. So behavior disorders occur about, it depends on the type of ADHD, but an episodic, there's something called episodic rage disorder. These are children who are kind of a sweet personality, and they're generally well-behaved and obedient, but when they lose their temper, it's like it can be like a volcano erupting, and it's called, psychiatrists call it episodic rage disorder, and about 50% of people diagnosed with ADHD have this problem. It's not just a matter of learning and concentration in school. It also means they have these behavior upsets. Oppositional defiant disorder. These are children who have a really strong will. I like to say a will of iron, and they're born that way, by the way. And that has to do with undermethylation. And 35% of our patients have that. Conduct disorder. These are children who not only have behavior problems, but they like to destroy things, and they tend to get in fights, and that's about 20%. Fortunately, it's only 1 in 5, but still, for those 20%, it's a major problem. Antisocial personality disorder. Now, that is an extraordinarily severe inborn behavior disorder. These are the people that, as adults, they're often called sociopaths. Fortunately, it's only 4% of those with ADHD. And I'm happy to say that we've had really good results in helping children with that imbalance. But we learn we have to get them young. You have to get them before puberty to really help them. So the treatment for oppositional defiance focuses on serotonin and NMDA. Serotonin levels seem to be really low in oppositional defiance kids, and also their NMDA receptor tends to have low neurotransmission. And the primary treatment for them is either SAMe or methionine, which are methylators, to enhance expression of the reuptake gene for serotonin. Again, it's not the amount of serotonin that determines serotonin neurotransmission. That's about a 5 or 10% effect. It's the reuptake, the genetic expression of this SERT reuptake gene. And methionine or SAMe tend to really enhance that, and the folates do the opposite. So the folates, which are good for undermethylation, they tend to make oppositional defiance worse. So it's because of epigenetics, which is a new field that we're learning more and more about. And we also want to promote glutamate activity at NMDA, and it can do that really nicely with antioxidants, zinc, selenium, GSH is glutathione, and there's recent research showing that NAC, N-acetylcysteine, is really effective for doing this. So if I were to add something to the list, it would be NAC. So case history, Mary, age 10, she had a very strong will, oppositional to authority. There was no reward you could give this girl that would make her change what she did, or there was no punishment that would be enough to make her change. She just refused to respond to, you might say, the carrot and stick approach, also known as behavioral therapy. But she was defiant. She was really quite bright, refused to study, didn't like her teacher. She was in a special classroom. She was engaged in counseling, which probably helped to some degree, and she was taking Vyvanse medication. When we tested her, she flunked the test for blood histamine. Her histamine was 153, whereas normal is between 40 and 70. So she had severe undermethylation. She was born with that. None of this was her family's fault, and really it wasn't Mary's fault. She was born with these very tendencies. Her zinc level was not bad. Her copper level was okay, and everything else was okay. The only problem she had was her histamine level was extraordinarily high, and that's a marker for methylation. It's not the histamine that's important. It's the methylation that's important, and the low serotonin activity that indicates. So the outcome for Mary, her treatment, we gave her methionine. Calcium, magnesium are augmenting nutrients. It'd be better if her zinc level was a little bit higher, and B6 also is helpful in the synthesis of serotonin, so she had some B6. and then some antioxidants, selenium, vitamins A, C, D, E. After week 4, we got reports of improvement, and then slow gradual process, and it really took 3 months. Undermethylation is the slowest imbalance to respond. It takes a long time to change the reuptake of serotonin from the synapse. And what we're really doing is we're changing the population of these reuptake proteins that are passageways in your brain cells for, in this case, for serotonin that's in the synapse to return to the original cell. And that dominates neurotransmission. Anyway, the good news is Mary returned to mainstream classroom. She became more cooperative. She still had a strong will, but she was willing to do homework. The counseling was continued to seem to be helping and no longer needed the Vyvanse. Some of the children we see, 50% of the ADHD have this episodic rage disorder where they have really good behavior with episodes of anger. It's often called Jekyll-Hyde behavior. But one characteristic is once they calm down, they usually have genuine remorse. The problem is it just keeps happening over and over. Typical chemistry is usually either a pyrrole disorder or a copper-zinc imbalance. And so we test for pyrroles, we test for the metal metabolism, and we act accordingly. If they have a pyrrole disorder, that means striking deficiency of B6 and zinc. If they have a copper-zinc imbalance, we use the treatment described before to bring the copper level down to normal. Sometimes we have to do both. Treatment approach is, again, normalizing serum copper, plasma zinc, and urine pyrroles. John, age 14, another case history. He was a good student, cooperative, he had a lot of friends, generally calm, but he would have rages daily. But I recall with him, it was 5 or 6 times a day. He would just have these uncharacteristic anger outbursts. He was engaged in counseling and Zoloft, and we were told that they both seemed to be helping, but he was still having rage outbursts, although not quite as frequently. Again, retesting his pyrroles turned out to be normal, so we didn't have to worry about that. But his copper-zinc imbalance was shockingly high. It was extraordinary. In fact, we were wondering why his behavior wasn't worse than that, considering his chemistry being so terrible. And he was born with this. Copper level should have been around 80 or 90 or 100. It was nearly double that at 189. Zinc level should have been above 100, and it was low at 76. So the treatment is this gradual introduction of zinc, and we have to do it gradually because we don't want the excess copper to leave too quickly. So we've learned that to avoid side effects, we need to build up the zinc level gradually, maybe over 2 or 3 or 4 weeks. And again, antioxidants are really important, vitamin C, E. We continued the Zoloft, continued for 2 months, but then they found he no longer needed Zoloft. And so he did well. Now, I want to point out that not everybody gets better. I don't want to give the impression that every single patient responds. However, we've done a number of outcome studies, and we've published a couple of peer-reviewed studies. And what we know is that about 80 to 85% of our patients report improvement, and their doctors report improvement. It depends on the imbalance. If pyrroles are the only issue, that's about 90% of them report great improvement. Copper zinc is more in the 80 to 85%, and those that have the undermethylation and the very strong will and ODD, oppositional defiant disorder, that's more around 65 or 75%. That's still very good. I mean, I think it's better than you'll find with results that are published for psychiatric medications. But again, I don't want you to get the feeling that everybody gets better. So anyway, for John, the bottom line was no progress until week 4. And the reason is that he was undermethylated. And it takes a while for that to be fixed. Rage is complete, and the zinc, again, takes 6 weeks, really, the zinc and copper. And his rages were completely gone after 10 weeks. And that, I think that usually happens in my experience, although not always. And he didn't, the counseling that had helped him was no longer needed at a Zoloft, and he just seemed to be fine after that. So conduct disorder, these are the kids that tend to be bullies. They break things. When they have a behavior upset, they might strike out at someone or break or damage property. And most of them have a pyrrole disorder. Most of the conduct disorder kids, they flunk our our urine pyrrole test. And pyrroles are chemicals that are created in the chemistry in our bone marrow, and they tend to be, because of genetics, they tend to be really elevated in some children. And what they do, the pyrroles are just they leave the body through the bloodstream and through the urine. The problem is they have affinity for B6, and they strip zinc out of your bloodstream. And they also strip zinc out of your bloodstream. So it causes a double deficiency if you have pyrroles. We always rejoice when we find a patient with pyrroles, because we get the quickest and the most striking improvements with people with pyrrole disorder. Many of them have a copper zinc imbalance that has to be addressed. Some of them have elevated toxics. In fact, some children, we find the only problem was high levels of lead or mercury or something like that. But that's why we have to do the medical process and do the lab testing and to identify what is the problem, so we'll know exactly what to address. So Brian, I remember him very well because he was the son of friends of mine. He was the son of a PhD chemist who was quite brilliant, and his mother was a master of social work who was renowned for really being effective at helping children with behavior disorders. But her own child had a really severe behavior disorder. He was adopted. He was adopted from an Indian tribe, actually. The parents were dedicated, they were capable, but by the time he was 16, he was violent, destructive. He wouldn't go to school. He was truant. He's failing every course. He was taking counseling, not his mother, but someone that she knew was good, and he was taking Prozac because it seemed like that was an issue. But when we tested his chemistry, we were happy to find out that his pyrroles were sky high. Normal is between 8 and 10. He was 82. And again, this was not his parents' fault. It wasn't his fault. He had an inborn tendency. He had a genetic or possibly epigenetic difference in his chemistry that caused him to be like that. So the treatment, of course, zinc and B6, which would fix the pyrroles, and that would bring his pyrroles down, and that would allow him to have normal B6 levels in his bloodstream. And you need B6 for so many things, and normalize the zinc. We also gave him P5P, which is sometimes a more effective version of B6, biotin, primrose oil, because people with high pyrroles, many of them actually have excessive amounts of omega-3 fats and are low in omega-6. They're the exception to the general rule. And these are the ones who do well on primrose oil, which provides them with arachidonic acid and other forms of the omega-6 oils, and vitamin C and E. As you can see, everything here has to do with individuality, finding out what a person's biochemical individuality is, and then finding a way to normalize it. So for Brian, he got clearly better after 7 days, and that happens with pyrrole disorder. Sometimes I hear families say that after 2 or 3 days, children who were impossible to deal with and were violent and really behavior disordered would just suddenly be dramatically different after 3 or 4 or 5 days. And that does sometimes happen, although often it takes a month. After 2 months, he was now calm. He ceased truancy. He started going to school, and to everybody's surprise, he was smart. The family said they didn't know that. Became an honor student, even joined the football team. I also found out that since he was so dysfunctional, that he had very few friends and never had a girlfriend. And on his follow-up visit, he proudly said that he now had a girlfriend. And the bottom line is he became a college student instead of a high school dropout. We wonder how many children in America are like that. My guess is it's probably hundreds of thousands, maybe a million. We've done outcome studies because you need to do research. Just because you get reports of somebody getting better, that's what science and psychiatry calls an anecdotal case history. And to a scientist and to the field of psychiatry, you have to discount anecdotal case histories. In other words, you could have a therapy that might have helped 100 people, but that's not proof that it works. You need to do careful scientific studies, preferably double-blind controlled studies. And we're engaged in that activity ourselves, and we think that's what's really necessary. I think that psychiatry and science deserves that. So our very first one was back in 2004. We had the Pfeiffer Treatment Center was a clinic that we were operating at that time, and we had a lot of behavior disorder subjects of all ages. We decided to, over a 3-month period, to test all 100% of them. So we had 207 behavior disorder patients. We identified their biochemical imbalances, and we provided them with a nutrient therapy to correct whatever imbalances we found. And then we measured the frequency of physical assaults. How many times did they physically attack another human being? And property destruction. How many times did they destroy property before the treatment and then after? And we published this in a peer-reviewed journal, Physiology and Behavior, 14 years ago, a long time ago. And this is what we found. This is the data. We found that 91% of the families and their doctors reported improvement. 58% said that the symptoms, they became symptom-free and completely stopped the destruction of property and to stop their violent activities. 33% said they had a partial improvement, and many of those improvements were really pretty good. In fact, wonderful. I remember a family from Connecticut told me that their child had been violent 10 times a day, and now it was once a month, and life was better for the family. But they were one of our 33% that had partial improvement, and only 9% failed to improve. This is the same group for destruction of property. The results were not quite as good, and in this case, 12% of them were still destroying property, but the results were exciting. We presented this at the American Psychiatric Association. I was asked to report it to the United States Senate and to the Surgeon General's office, and did those things. And so we continued to do research on this. In 2017, I was part of a Australia violence study. In this case, it was a collaboration with Griffith University, and our doctor was Dr. Kelly Francis, someone who we had trained for over 4 or 5 years, really. And we had 32 violent males, violent in terms of physical violence, not verbal violence, ages 4 to 14. And we used standard evaluation instruments used by psychiatry and by learning specialists. The tests are called CAS, MOAS, and anyway, these are standard ways of measuring learning capability, attention, etc. This was published last year in a peer-reviewed journal, and it was an open label trial. The results in the Australia study confirmed what we had found before and what we were quite confident was happening. Every one of the scales indicated impressive efficacy. Reduced violent behavior, the p-value, which is the probability that this was just an accidental fluke, was less than 0.001, which means there was less than 1 chance in 1,000 that we didn't really have efficacy. The side effect profile was very, very low. In other words, the treatments, people taking our treatment, there was little or no side effects reported because of our treatment, because we don't we just normalize biochemistry. We're not giving a powerful drug to go in your brain, which can cause side effects. We are just simply attempting to do the best we can to normalize their chemistry. And it replicated the earlier study. So overall, what do we recommend if a family finds themselves with a child diagnosed with ADHD? We think you should check out their chemistry. We think you should find out whether this is something that is not related necessarily to their environment or their life experiences. We think you should check their labs, check their blood and their urine to see if they have chemical imbalances that are part of the problem. So metal metabolism, pyrroles, methylation, toxic metals, and a few other tests. The lab testing that we do, we've got a protocol we use for lab testing, and it tends to cost between $300 and $400 to do this testing. And usually we have the answer whether or not the ADHD patient or individual has this as part of the problem or not. And usually the answer is yes. And then we recommend them, refer them to a medical doctor who knows these nutrient therapy protocols to normalize their biochemistry. And we regard drug medication as a last resort. Yes, Ritalin, Adderall, and other amphetamine preparations, they are somewhat effective. And in fact, I think in most cases they are somewhat effective, but we think of it as more of a last resort. And if needed, fine, you should use it. But we think the individualized nutrient therapy is definitely a better way to begin. That and counseling, I think, should precede use of drug medications. So I'm going to turn this over to Dana, who is our moderator, organizer.
So at this time, we're going to begin the question and answer portion of the webinar. So please type your questions into the control panel. And while you're doing that, I'm going to take a moment to remind you that the nutrient therapies described by Dr. Walsh during this webinar do require the supervision of a medical physician. You can find a doctor in your area that has that utilizes Dr. Walsh's protocols by visiting our website, which is walshinstitute.org, to find a doctor in your area. We do recommend that you seek the help of an experienced physician who has attended a Walsh Research Institute physician education workshop, because as you've learned today, nutrient overloads and deficiencies have a powerful impact on brain functioning. And I'm seeing here that there are many questions about, will the recording and the slides be available? Yes, you will have access to the recording, and I'd be happy to send all of you attendees a copy of these slides. So first question is, which SNPs are associated with weakened MT function? Dr. Walsh.
Well, there are many, and it's not just SNPs. SNPs are you might say, mutations in genetically expressed chemicals. See, our DNA does more than just determine the color of our eyes and how tall we are and whatever. We depend on our DNA to serve us all day, every day. They organize the nutrients that every cell receives, including our brain cells. And the problem is that these chemicals, these enzymes, and these proteins that are genetically expressed, they're usually rather large. They might have as many as 500 or 1,000 amino acids in them. And what a SNP is one of the amino acids is out of place. For example, the MTHFR gene, which is now quite popular and is important in methylation, it has more than 500 amino acids, and if you've got, and there are more than 80 SNPs that have been found in that enzyme. However, 2 of them are especially important, and what they do is they weaken the enzyme. And so they tend to impair and weaken their activity. Now with ADHD, I think for those who have ADHD with a methylation disorder, it's usually SNPs and MTHFR, although there are others, but usually it's MTHFR, either the 677T or the 1298 SNP. But there are others in that whole methylation profile. If a person has a copper-zinc imbalance, the SNPs almost certainly have to do with genetically expressed metallothionein, which is a shorter linear biochemical that is expressed and it has the job of regulating the metals. And so even though it's a smaller enzyme and with fewer SNPs, these SNPs have a greater impact, and they can really impair that, and they can cause the copper-zinc imbalances we talked about that affect so many ADHD kids. The pyrrole disorder, we don't know yet. Science has not yet determined which SNPs are maybe responsible for that. We know it has to do with the biochemistry in your spleen and in your bone marrow, but they've not yet identified what the SNPs are. But eventually we'll find that too.
Okay, so in regards to the elevation of copper, does that only apply to patients with ADHD hyperactive type, or does that apply to inattentive type as well?
We've seen elevated copper-zinc ratios across the board, really, but it's especially high in hyperactivity. It's also one of the major causes of depression, especially for females. An elevated copper-zinc ratio seems to be really important in postpartum depression. And I would say that's about 95%. And we have found in treating more than 800 cases of postpartum depression that we have something like a 90% of them report that their depression is either better or gone. And it has so much to do with an elevation of the norepinephrine and a diminishment of dopamine. And so we can find the copper-zinc imbalance in many different kinds of cases. For example, autism. About 85 to 90% of children with autism have a copper overload, especially free radical unbound copper. So copper abnormalities, I think we find them throughout all types of mental health, even schizophrenia and bipolar disorder. So, and it depends on the individual, which is why one has to carefully look at their blood and urine chemistry and their symptoms and traits in order to diagnose exactly whether or not this is part of the problem.
Now, Cindy is asking, how are you testing for pyrroles? This is for pyrrole disorder.
Well, pyrrole disorder has got some really striking symptoms and traits. And I've gotten to the point now that I've seen so many of them, I think I can identify people with pyrroles just walking down the street. But the key test is a urine test for the concentration of pyrroles. And we know what normal is. And if a person has high pyrroles in their urine, that means that I think of that like having a hole in the boat. Most of your copper and your zinc and even your toxic metals, most of them will leave through the stool and not through the urine. And what happens is that your zinc is supposed to be regenerated over and over. And what happens if you have pyrrole disorder, you're just losing lots and lots of your zinc through the urine that you're not supposed to be losing. And zinc is actually that's the natural nutrient that causes this metallothionein protein to function, and it affects the part of your DNA called a metal regulation element, and so it's an epigenetic effect, and so that I think the symptoms are so clear with pyrrole disorder. For example, these are almost always night people. They're not hungry for breakfast. These are the people, one symptom is they tend to skip breakfast and don't care if they eat in the morning. They tend to have pale skin. They're more prone to sunburn than others. Because of the pyrrole disorder and the severe zinc deficiency, their taste is different, and they tend to love spicy foods. Um, they're just they also are prone to mood swings that are quite dramatic, and they're usually famous for their temper, regardless of how wonderful they might be, and when they're okay. So, but I think that's basically a urine test. There are only about 3 or 4 labs in the world that do that test right, and if you check our website, I think you'll find the labs that do that properly.
Yes, information regarding laboratory testing and practitioners is available on our website, walshinstitute.org. And it really depends on the practitioner whether they accept insurance or not. It depends on what type of practice, whether it's run independently or they're with a larger group organization. I realize that some of you have specific questions about other countries, and so for those questions, you may send me an email to dana@walshinstitute.org. And we realize that we won't be able to get to all of your questions today, but if we don't get to them, you can email them to me and we'll try to get to them later this week. So the next question from Jody is, hi, my son is 17 years old. He's struggling with OCD. We have tried vitamin B6, tryptophan, 5-HTP, and NAC. What are the other options for this patient or for this young adult who's 17 with OCD?
Well, everything you're doing, I think, is a positive. Everything you mentioned is something that would help to some degree. One of the factors you almost always see in OCD and OCD tendencies is undermethylation. So I think methylation therapy is something that should be tried, and I would recommend you find a doctor who knows how to help with that. And the one thing that has to be emphasized is that even though your 17-year-old is almost certainly undermethylated, he needs to avoid all forms of folates. And the reason is because we've learned after thousands and thousands of patients that for those who have OCD, that even though the folates would improve their methylation, the patient would get worse. And the reason is that folates affect gene expression, and they affect gene expression of these reuptake proteins. And part of the problem with OCD is almost always low serotonin activity, and folates cause your serotonin activity to collapse and to drop, even though the methylation gets better. So just want to make sure you're aware of that.
Mm-hmm. This person is saying, I'm an undermethylator and I've tried the methionine treatment. It was not effective. Why?
The methionine and SAMe treatment for undermethylation is only effective if the rest of the cycle is okay. And for example, we would never give methionine or homocysteine or SAMe to anyone with elevated homocysteine. And the reason really is that when your methionine converts to SAMe, S-adenosylmethionine, which is you might call it activated methionine, and it's the methyl donor in the body. And if now once the methyl is given up to make a methylation reaction, the chemical becomes something called SAH, S-adenosyl homocysteine. Well, some people who are undermethylated have really high levels of SAH, and you must not give those people methionine or SAMe until you first get the homocysteine and the SAH down. And our doctors that we've trained understand that, and it is a bad idea just to give methionine or SAMe to an undermethylated person without checking that out first. And there are lab tests that are quite effective at determining that. There's a doctor's data laboratory has a methylation panel that can tell you exactly what the SAH level is, and it can identify blocks in that whole methylation cycle. And so there are ways of identifying that, and I'll bet you have one of those blocks. Otherwise, you would have improved.
The next question is, how do you tell if your child is an over or under methylator? I have had doctors give my daughter supplements that you use for both.
All right, and undermethylation affects 8% of the U.S. population, and I think it's probably similar around the world. And 22% of Americans are undermethylated. That is, they have below average methylation capability. And the treatments for those are well established, but they need to be done by a doctor who knows what they're doing. And so there are growing numbers of doctors that know how to do this. We have doctors who are doing these and now I believe in 30 different countries. The book Nutrient Power is now in 7 different languages, so this is spreading throughout the world. But you need to have a doctor that knows what they're doing. And if we're dealing with methylation, you have to be especially careful, because you can do harm if you go in the wrong direction. If you have an undermethylated person and you give them something that worsens their neurotransmitters, you can cause harm. So I think you have to be really careful with methylation therapy.
Mm-hmm. I've read that there's controversy on the accuracy of tests for heavy metals like mercury and lead. What have you found to be the best type of testing for heavy metals?
Well, the problem with heavy metals is that they don't stay in your bloodstream very long. The half-life, for example, if a person accidentally got a shot of mercury in their diet accidentally, or a thermometer was broken. By the way, we apologize for the noise in the background. Somebody's mowing their lawn. If you got a shot of mercury, that would not show up in your bloodstream after 3 or 4 days, and it would show up in your hair, and it would because some of the toxic would wind up in your hair. And I kind of like to use a hair analysis from a competent lab, and there are a couple of really good ones. And I know there are good ones both in USA and in Australia and other places. And the EPA has published the recommendation that for identifying toxic metals, that hair analysis is better than blood or urine. Although once in a while the toxic levels are so high you can actually see them in blood and urine, even a few days or weeks after the imbalance. The exception is lead. Lead in the body, the half-life of lead in the body is 22 years. And that's because lead acts as though it's calcium and gets absorbed into your bones. So if a person who has a lot of lead exposure, it's going to be with them to some degree the rest of their lives. But I think hair analysis is a good way. There are challenge tests that can do this, but the challenge tests often are not done right, because the heavy metals, whether it's mercury, lead, or whatever, 95% of that goes out in the stool. And if you do something like a challenge with DMSA or DMPS or EDTA, those of you familiar with challenge tests, if you do a 24-hour urine sample before and then do a 24 urine sample after doing this chelation, of course the level in the blood is going to be higher, because you're sending it out a different door. Instead of only 4 or 5% of the toxics going out in your urine, you're forcing nearly all of it out. So these challenge tests, urine challenge tests, can be done if somebody really knows what they're doing. In my experience, more than 3/4 of doctors that do this are not familiar with metal metabolism, and they'll repeatedly do these challenge tests and say, hey, we're getting more mercury out, or we're getting more lead out. No, they aren't. What they're doing is they're just causing, sending the whatever toxics leave the body out through a different door, out through the urine instead of the stool.
So treatments for copper zinc imbalance, right? A lot of kids with these issues have copper zinc imbalance. When they get on a successful treatment program, what does that treatment program entail? Are they on the supplements that correct their biochemistry into adulthood?
The answer to that is yes and no. If anyone has a copper zinc imbalance and it gets corrected with nutrients, which might require for that imbalance alone maybe 2 or 3 or 4 capsules of a variety of nutrients, it'll come back. In the case of copper zinc, the imbalance will probably they'll feel fine for about a month, and then after 2 or 3 months they'll be right back where they were, and all the symptoms will be back. I said yes and no. The reason why some people don't need this is that when you're young, when you're growing, when your cells are rapidly dividing, every time a cell divides, you use and you lose zinc. So once you stop growing, once you stop growing, the zinc deficiency part of that is just naturally weakened, and things tend to get better. And a number of I think it's a good idea to retest somebody, say at the age of 20, that may have had a copper zinc imbalance before, and it may no longer be severe and may no longer need to be treated. And a lot of children we've seen, and a lot of adults we've talked to, I've talked to a lot of adults with copper zinc imbalances, and many of them were late bloomers. In other words, had great difficulty in school or had difficulty with behavior. But in their 20s, they changed dramatically and became late bloomers. And a few of them said they loved to go to high school reunions because nobody could believe how well they turned out. And I think the drain on zinc from growth is no longer there, and so it corrects part of the copper zinc imbalance. So I apologize for the long answer, but that usually if you stop taking the treatment, it will come back. So we can treat this, but we can't cure it.
Mm-hmm. Now, in regards to omega-6 and omega-3 levels, do parents need to have their children checked for those levels?
Well, for ADHD and behavior, we find that that it's only about, I'd say, between 4 and 8% of people really need to have the fatty acid levels tested, because what we're looking for are genetic abnormalities. Every patient that we would have, and every doctor that would do this right, would make sure that the person had a good diet. So if you have a proper diet, then the question is, do you have a genetic abnormality? Like the severe pyrrole people have the odd situation of having more than enough omega-3 and not enough omega-6, whereas nearly all, I would say 95% of American children probably have too much omega-6 and benefit from omega-3 fatty acids. So we don't usually test fatty acids on our first screen. The reason is about 90% of our patients get better without having to get involved with fatty acids. And also, fatty acids are more difficult for a child or even an adult to take. There's a lot more to swallow down, and so there's a problem with compliance. We try to avoid the fatty acids unless we need them, because it tends to knock compliance down greatly, especially for children.
Mm-hmm. Next question is, can these imbalances be tested at birth or in parents prior to conception to identify children who are prone to these behavioral disorders so that nutrient therapy can be initiated early?
Well, the problem is that the reference levels for blood and urine factors at birth are very, very, very different from even when they're 2 years old or 4 years old or adults. So we'd rather not do that. I think eventually we'll be able to do that, but there are extraordinary levels that you can find, but we usually don't recommend pediatric testing. We like to have a patient be at least 1.5 years or 2 years old. I've seen more than 6,000 children diagnosed with autism, including some very young ones. And we found that unless they were at least 18 months old, that the lab results were not reliable in identifying their chemistry. Every tiny child tends to be really low in zinc, and that's normal for many of them because of the rapid growth going on. Another thing I'd like to mention is that testing of the parents It's not a bad idea, especially if one of them has a striking imbalance. But a baby is not, you're not a combination of your mother and father. You really have genetic material from many of all a combination of your ancestors, and you might be taking after an aunt or uncle from 3 generations back. So it's not a bad idea to try to identify something that might be running in the family. For example, we know that copper zinc imbalances and pyrrole disorder and methylation, all of those tend to run in families. But again, you get exceptions because of the variety of ancestors that we all have.
Mm-hmm. Just taking a moment to read through some of your questions. We have a few more minutes. You mentioned a slow dosage of zinc introduction. Can you describe the importance of that?
Yes, if a person has really an excess amount of copper in their body, when we treat it, it leaves the body through the bloodstream, and the symptoms are generally irritability and anger. That is the most common symptoms you get. So if you do it too quickly, if you are causing the excess copper to leave too quickly, the blood level of copper will go too high as it's leaving the body, and you can get those symptoms. That's typically the issue. For people with postpartum depression, we have to be especially careful, because for them, if we don't do this really carefully and gradually, their depression could possibly get worse, and that could be a lot more serious.
Are pregnant women at risk for copper zinc imbalances?
That's really interesting. A lot of women who develop postpartum depression had no tendency for depression or anxiety at all before they had a child. The reason is that during the 9 months of pregnancy, a woman's chemistry, a woman's blood level of copper more than doubles. Typically, it should be around 80 or 100 micrograms per deciliter, and it tends to go over 220. And that's healthy, because the baby needs that. The fetus needs that because of the rapid growth. And so what's supposed to happen right after delivery, the copper level in a mother is supposed to go right back down to normal. But some people don't have that capability. And it's usually metallothionein that I discussed before. If they don't have the capability of getting rid of excess copper, which is what metallothionein does, then that causes extraordinary anxiety and depression related to norepinephrine and dopamine abnormalities because of that. So yeah, there are a lot of people who develop postpartum depression or postpartum psychosis, and it's really because when their copper escalated during the pregnancy, they couldn't bring it back down. Now, we know how to bring it back down, but most doctors don't. But if anyone with postpartum depression or the history of that should, I think, check out their plasma zinc and serum copper, because they might still be having some problems related to it.
So if their levels never returned to normal, and then they got pregnant and they had a child or son or daughter with ADHD, and could that be possible that they shared their biochemical balance with their child?
I think there is a definite connection between postpartum depression of the mother and ADHD and the child.
So does any of this information that you've shared today, Dr. Walsh, apply to children with autism? We have a son that constantly paces, has low verbal ability, and has rages.
That's very common, and again, I've seen more than 6,000 cases of autism. In fact, it was our database. We were the ones that first, back in 1998, we were the ones that first identified and discovered that autistics tended to be undermethylated. And at that time, when I reported that to the rest of the world, it seemed like nobody even thought about that as a possibility. But yes, about 95 to 98% of all persons diagnosed with Kanner autism, with classic autism, not necessarily what they call autism spectrum, but with they have undermethylation, and that tends to cause ritual behavior and a tendency for stimming, but also a tendency for being creatures of habit. Um, yes, I think that, and there in America there are hundreds of doctors who are really quite capable of addressing the methylation problem in autism. And I just urge anyone with an autistic child to act immediately, because I've learned with the thousands that we've worked with, you can get more progress with a 2-year-old in a month than you can in a year with a 6-year-old. So early intervention is everything. Autism is treatable, recovery is possible, and I think that every child deserves that possibility.
And even adults with autism, advanced nutrient therapies could help with some behavioral issues.
That's true, but it's one of my disappointments is that since autism is a developmental disorder, a person who, an adult with autism, if they have, again, classic Canner autism, their brain isn't the same. And we know in what ways their brain is different. They have different connectivity of different parts of the brain. We know that their neurons that form these connections, they're called mini columns in your cortex of your brain. We know that they're different. So once an autistic gets past, maybe I would say, puberty, it's more difficult to help them. And yes, you can help them. You can provide them with a better quality of life, especially if they have behavior issues, as many of them do. Very often, we can help an autistic adult who might have constant rages and upsets and make their behavior calm. We can help them with a better quality of life, but the possibility of a complete recovery is almost vanishingly small if they truly have autism and they're past the age of 14. I'm sorry to say that, but that's my experience.
And what about borderline personality disorder? We've had a couple questions about that.
Borderline personality disorder is an interesting diagnosis. I have a lot of good friends who are psychiatrists. They tell me when a psychiatrist diagnoses borderline personality disorder, that means they don't want to see the patient again. They'd rather not have that patient. Partly because there are no treatments that are reliably can help people with borderline personality disorder. We have tested more than 500 cases of borderline personality disorder, and I think by just normalizing their biochemistry, we've had better success than psychiatric medications for those people. And there's many different types of borderline personality disorder, and the diagnosis itself. Most people that have a diagnosis of borderline personality disorder will come in with completely different diagnoses. So the diagnosis itself, I wouldn't take it as an established fact if you have someone in your family with that diagnosis.
Mm-hmm. Do you have any experience with Tourette's syndrome together with Asperger's syndrome with your Walsh protocol?
Yes, we've had a number of cases of patients with Tourette's syndrome. And we know a lot about that. The problem is that Tourette is what's known as an epigenetic disorder. That means that this person's DNA is permanently changed by some environmental insults, one or more environmental insults. And so the Tourette is not likely to go away ever. They're going to have to face that the rest of their lives because their gene expression has been changed. It's almost always related to undermethylation. So methylation therapies can certainly help. There are therapies that are about 15 to 20% successful in almost eliminating Tourette's. We know that cesium chloride, for example, can be really helpful. And free-form amino acids, that is the amino acids that are not in proteins, but have been separated into the individual amino acids. That cesium chloride and free-form amino acids are helpful, along with trying to normalize methylation as best as possible. That That's the approach we've taken. We get a really nice response with only about 15 or 20%. We get, I think, about 80% say there's some marginal improvement. But Tourette is difficult. I think mainly because it involves a permanent change, or at least a semi-permanent change, in probably 50 or 60 genes.
Mm-hmm. We only have time for a few more questions. The next one is, do these ADHD and behavior disorder nutrient therapy treatments also help adults as much as they help children?
We've had thousands and thousands of adults with ADHD, and the interesting thing for me is that the chemistry is the same. The chemical abnormalities and imbalances are the same, but it takes longer for an adult to recover or to respond. What would normally take 6 or 8 or 10 weeks for say a 10-year-old or a 12-year-old, it might take as long as 4 or 5 or 6 months for the adult to get the benefit of the treatment. Chemistry is the same. We can normalize the chemistry, but they have to be more patient and they have to hang in there for a longer time with the treatment. But my experience is if they're able to do that, they can get really the same results.
Mm-hmm. Okay, our last question for today. If getting our child tested and evaluated by one of your Walsh physicians is not financially feasible, would it be okay to try and give a child or my teen any of these supplements that you spoke about to see if it would make a difference?
Well, I don't recommend it. However, we have a lot of people contacting us from Africa and from third world nations where they don't have the ability to do testing, much less the money to do the testing. I would, if that was somebody in my family and I was in that situation, I would study this as much as I can, because you can do a pretty good job of identifying chemical imbalances with symptoms and traits. And I would do the best I could. But really, if you can afford to have a knowledgeable doctor, that is absolutely the best way. And there's only if a person is living in outer Mongolia or something where that's not possible, you still would have. I think you should still do the best you can, but you really need to do the lab testing.
Well, and the takeaway is that what you've learned today is that all children are biochemically unique. So what one child may need is very different from the other. So to walk into a store and to try supplements randomly here and there would do a disservice to your child, and improper treatment affects brain neurotransmitters. So we do not want to cause harm.
I'd like to mention that when I first started doing clinical work, the greatest surprise I had was, and it was a big surprise, was that yes, a lot of people have, because of genetics or diet, are deficient in nutrients. But what I learned, to my surprise, was that the greatest mischief is caused by nutrients that are in overload. And that's why multiple vitamins usually don't work. You're usually making matters worse with those nutrients that, because of genetics, you're overloaded in. So really, you cannot help a person by just stuffing them full of amino acids, vitamins, and minerals. You know, the odds are they'll be somewhat worse.
Okay, thank you all so much for joining us. I'm sorry that we didn't have time to take all of your questions, but again, please feel free to email me at dana@walshinstitute.org. Visit our website, walshinstitute.org, for more information. And also, please remember to visit our friends at NHRI, Natural Health Research Institute. Their website is naturalhealthresearch.org to sign up for their latest health research articles and their monthly newsletter. Thank you.